That's my badge.
Buenas tardes ya. Buenas tardes. Como presidente del 56º Congreso SEPAR de Granada, es para mí un auténtico placer y un gran honor tener la oportunidad de presentar la conferencia Manuel Tapia de este Congreso. Hay personas que a lo largo de su vida son capaces de concitar la suma de energías necesarias para cambiar en cierto modo la realidad en la que se encuentran y, en este caso, aportando conocimiento, marcando tendencia por su forma de hacer y estudiar e interpretar la realidad. Y con esas personas son las que de alguna manera nos impulsan a crecer, nos sirven como guía y referente y que consideramos auténticos maestros en los que vemos reflejado lo mejor de lo que queremos ser. La conferencia Manuel Tapia constituye, como todos saben, el acto central del Congreso SEPAR y tiene como objetivo homenajear a alguna de las personas que han llegado a ser un referente en el ámbito de la neumología. En este 56 Congreso SEPAR en Granada 2023 tengo el honor de presentar ante ustedes para la conferencia Manuel Tapia al doctor Jorgen Vestbo. No necesita presentación probablemente para ningún neumólogo, no solamente de SEPAR, sino de cualquier parte del mundo. Como saben, el profesor Jorgen Vestbo fue graduado de la Universidad de Copenhague en 1984 y se formó posteriormente en los hospitales de la región de Copenhague. Desde 2023 ha sido profesor de medicina respiratoria en la Universidad de Manchester, desarrollando simultáneamente su labor como profesor en la Universidad de Copenhague y del sur de Dinamarca. Actualmente se encuentra felizmente retirado de Manchester desde marzo de 2023 y ahora trabaja en su propia clínica en Copenhague y además simultanea su labor en un comité asesor del Protocolo de Montreal de la ONU sobre los aerosoles y cambio climático. Sería imposible resumir en poco rato el currículum del doctor Vestbo, ni tampoco es ni mucho menos el objetivo de esta presentación, porque desde luego el protagonista absolutamente es él. Es un investigador altamente citado y su investigación se centra en aspectos clínicos y epidemiológicos de la EPOC y estoy seguro de que a este respecto todos los neumólogos somos capaces de recordar algunos de sus trabajos. Ha trabajado en estudios de cohortes en Dinamarca durante muchos años y copresidió el estudio Eclipse durante 3 años destinado a caracterizar mejor la EPOC. Y como todos ustedes saben, este ha sido uno de los estudios que más han influido en la toma de decisiones clínicas en los últimos años. Ha estado en comités directivos de varios ensayos grandes de eficacia y efectividad en la EPOC y ha sido presidente del Comité Científico de la GOLD y también presidente de la Sociedad Europea de Respiratorio. Actualmente vive en una casa al norte de Copenhague con su esposa, con la que lleva casado 40 años, cerca de sus 2 hijos y 4 nietos. Querido doctor Vestbo, muchísimas gracias por aceptar la invitación que le hicimos desde el Comité Local del Congreso SEPAR Granada 2023 para acompañarnos en este día tan especial para todos los miembros de SEPAR. Dear Dr. Vestbo, thank you very much for accepting the invitation we made from the local committee of the SEPAR Granada Congress 2023 to join us in this special day for all SEPAR members. Thank you very much for staying with us. Perdón, como todos ustedes saben, en la conferencia Manuel Tapia no hay preguntas que hacer. Cuando quiera, doctor Vestbo.
Thank you very much, Pedro, and thank you very much for SEPAR for offering me the opportunity and this honor it is to present here at your annual meeting at this lecture. I'm afraid that this is the only Spanish you'll see today, is the title, because unfortunately I will have to speak English, and I hope it will function. It's not my first language either, so mistakes from me and from you are acceptable, I hope, for all of us. I am going to talk about COPD from population to bedside. I'm not an epidemiologist, but I want to show you what the value of looking at diseases in a population can be. I'm not an epidemiologist, I'm a clinician, I see patients. But I like epidemiology because it tells me something about what happens with disease outside the clinic, outside the office. And I think it's far too important to be left to epidemiologists and health statisticians because you need, as a clinician, to be able to ask questions. Now, it is epidemiology, and usually people think of epidemiology something like this: huge tables, not very interesting, a lot of numbers, what do they really mean? And I know it's a challenge to talk about epidemiology. I talk epidemiology to students, it usually works like this, and I very often give presentations to a larger group of people with normally the same amount of success. So it's a challenge to talk about epidemiologists to non-epidemiologists, but I'll give it a try. Of course, from population to bedside comes from the saying, from bench to bedside. This is translational medicine. I've always thought as a clinician that there was a little bit too much from bench to bedside, and perhaps too little from bedside to bench, because I think it is the clinicians that could help basic researchers ask the right questions. But I think we should go much broader than this, because I think what we see at the bedside is not really the whole disease. And the reason is that even when we do studies in humans, like clinical trials, patients from our clinics do not make it into the trial. This is a very nice study of a group from Norway taking patients they see in their clinic, and then they see how many of them would make it into an exacerbation study in COPD. And they start sorting people out, that they cannot have too many symptoms, they have to have the right lung function, there cannot have been a history of reversibility, no comorbidities, and they end up putting very, very few patients from their real clinic into the clinical trials, on which they then relate what they do, not only to the patients in their clinic, but also to the patients they advise to the general practitioners to treat out in the population. So I think for me, it's about from population to bedside and the other way. It's the inspiration we get as clinicians and hopefully what we can convey to basic researchers when we see what's happening in populations. But it's also about what we see in clinic. Does it really work when we take it out in the real populations that will eventually, for instance, get the treatments or the other interventions we may test at bedside? If we look at the hierarchy of evidence, we're used to looking at whatever we do, it has to be based on numerous randomized clinical trials, hopefully so many that we can do systematic reviews. And if you look at it, you have to go quite further down to look at cohort studies, and even further down to look at cross-sectional studies, to look when you see the value of the evidence that these studies provide. And I think this is probably correct when you talk about treatments and causation, but if we look at information value, I think it is very different. Even GOLD has this grouping or evidence category, and you can see that as soon something is not randomized, it is automatically evidence C. I will come back later in my talk to why this is both correct and probably a bit too negative. I think this is a much better and more nuanced picture of how we look at effects in populations and different study designs. We have the registration RCTs, highly controlled, but very small limited populations, and then all the way out to being observational as they are managed out in the community. And there are a number of different study designs we can use in between. When people look at observational studies, I think the reason people lose confidence is that you looked at very many correlations in your own life. When you think all these things about people having a specific hair color and their risk of dying in a car accident, is that really causative just because it correlates? You can find all these things where one thing correlates to another, and sometimes it becomes not very trustworthy. I think my best example, which is also one of the funnier ones, is the correlation between the chocolate consumption in a country and the likelihood that they'll get a Nobel Prize. And you can see, not surprising, the Swiss are good at chocolate, but they also get a bit of Nobel Prizes. And I think if I lived in Spain, I would probably eat a bit more chocolate. But of course, this has nothing to do with causation, it's just correlation. And when we do cross-sectional studies, we run the risk of looking at correlations that make little sense. You cannot talk epidemiology without showing this picture, and to me it has been crucial. It was published in the British Medical Journal in the same year as I entered medical school, and it has basically formed my career. I always show the picture of Charles Fletcher, first of all because he's the first author of this study, but because he was a quite significant person in respiratory epidemiology. He coined the British hypothesis, saying that it was repeat infections that would lead to loss of lung function. He set up a study, studied men in London working in the post offices, and he could show that it was not the infections. It was the tobacco smoking that led, in some people, to a gradual decline in lung function. So he basically spent a decade setting up a study to show that he was wrong. Not many people are willing to do that and then actually write about it. I think he was quite significant in other ways also. I think he was doing public health at a time where it wasn't really appropriate, seen by the medical profession. He talked on the BBC about the need of doing public health, about not smoking, about living healthily, and he was almost thrown out of the British Medical Association because he was sort of accused of making a pop culture out of medicine. I think his study was extremely important, perhaps also misunderstood, because life is not as simple as this diagram depicts, and Fletcher never said it was. He kept stressing that he was studying biology, and he was just using this graph to illustrate the impact. But what it meant was that we could measure disease progression. And I think before we had the Fletcher study, there was very little to give the clinicians or the basic scientists about COPD and how COPD developed and progressed. But suddenly we had a proxy in FEV1 decline that we could use to characterize those who progressed and those who didn't. We could start looking for risk factors, and we did. Actually, when Fletcher did his study, he showed that mucus hypersecretion did not relate to lung function decline. Some years later, we showed in the Copenhagen City Heart study that it did. So was this just another example of epidemiology showing a little in the morning and something else in the afternoon? No, it wasn't. I think Fletcher did his study in a time where air pollution was very heavy in London, and the prevalence of having mucus hypersecretion was 60 to 70%. When we looked at it in Copenhagen, cleaner city later on, the prevalence was only 15 to 20%. And probably we pick up the inflammation signal that would drown in the study of Fletcher. So just having a mucus signal also would give both clinicians and basic researchers a tool, a way to look. Is this a target? Is it even druggable? Is it something you can use? So I think we provide risk factors that may also give insight to mechanisms. This is another study from the Copenhagen City Heart study by my good friend and colleague Peter Lange, looking at asthma being related to declining lung function. I don't know how many of you do epidemiology or do longitudinal analysis, but there are a number of models that we take for granted today, like mixed effects models, where we can model change over time very precisely. We actually applied mixed effects models to our data, submitted it to the New England Journal of Medicine, and was told that that was too fancy. We had to do linear regression. I thought that was quite nice, given that there are so many fancy things in the New England Journal I don't understand. But apparently epidemiology had to be simple. Luckily, it showed the same, and you can see that if you have asthma, you have a more rapid decline in lung function, and if you don't. The interesting thing here is that it is more pronounced in smokers than in non-smokers. So there is an interaction between having asthma, being a smoker, not surprising to a clinician, but still all clinicians accept that when we do clinical trials in asthma, we only take asthmatics without a smoking history. Is that fair? Not at all. Outside clinical trials, asthma patients smoke like everybody else. Does it affect treatment response? It definitely does. This is a study where patients are giving budesonide or placebo, and this is the effect of budesonide. And you can see on the left-hand panel that's on FEV1, and it's in non-smoking asthmatics, just as you would expect, increasing efficacy of the drug over time. But if you look to the right, on lung function, there's no benefit from the inhaled steroids in smoking asthmatics. And still, they're excluded from the trials on which we base our treatment subsequently. Also, of course, in these trials, the patients take their medication. In the real world, they don't. This is a study of what happens in the real world. When patients are prescribed medication, they don't take it as we expect. I had a mentor in pharmacology who once said that there was nothing that had saved as many lives as non-adherence. That may be true for some diseases, but probably not for asthma. We know things from numerous studies. This is from one of David Price's study, that people with uncontrolled asthma take less medication than those with well-controlled, and there are a number of reasons for it. Once we did a study called the TORCH trial, which just accurately failed to show a significant effect of drug treatment on mortality, but perhaps patients didn't take their medication. So we looked at adherence to medication, and you can see that those who had more than 80% adherence to the inhaled medication had a much better survival than those who didn't. Unfortunately, it didn't matter what they were adherent to. So those who were adherent to placebo had a better survival than those who were non-adherent to Seretide. And it just shows that it has nothing to do with the drug, as you believe everything has in a randomized trial. It has something to do with what we call the good adherer effect, that people who are adherent to treatment are also those who do exercise, they eat healthily, they take their other medications, all the things you should do to remain healthy and live longer. You cannot study that well. So people say, well, this is a clinical trial. Does this matter in real life? That's always, we need real-world evidence. And I'm sorry, but this is all real-world evidence. I don't know of a fake world. It's which part of the real world you look at. And we have this idea that the real world has to be outside clinical trials. In clinical trials, you can only have the biases of not doing real-world studies. I'll just remind you that if observational studies provided the truth, we would believe that inhaled corticosteroids as monotherapy, as well as statin, would reduce overall mortality in COPD, has not really been supported by clinical trials. We would believe that supplemental estrogen would reduce cardiovascular morbidity and overall mortality in women after menopause. And we would believe that bone marrow transplantation, in addition to chemotherapy, would increase survival in women with breast cancer. This is observational evidence seen for decades going back, completely refuted in subsequent trials. Perhaps I'll come back to that. But interesting that when you look at trials, you cannot use observational studies because there will be inherent biases. So probably you can test whether the effect of medications is the same in a population, and particularly whether they harm patients in the real world. But it's not either or. It's not either a randomized controlled trial or so-called real-world evidence. There is the possibility of doing pragmatic randomized controlled trials. And I'll just show you an example of one such trial, which is the Salford lung study. Salford is a small city just outside Manchester, where I've been working for years. And we did two studies. We did one in COPD and one in asthma. They were more or less the same, and they showed more or less the same. It was a simple study showing that if you took patients and randomized them to either continuing their usual medication or shifted them to a combination of fluticasone furoate and vilanterol, whether they did better on exacerbations. That was what we tested in the COPD study. And this is the study design. It was very simple, but it included randomization. But after we had randomized them out in their general practice clinics, without doing a lot of fancy tests, just randomizing them if they accepted to participate, we didn't touch them for a year. They didn't come for any visits. They didn't have any measurements for a year. We just followed them in registers, and then we took them in after a year. So this would simulate the real world. We included 2,800 patients, and we could see from GP registers that was actually half of the population with COPD in Salford. So it is possible to get patients in the real world into randomized controlled trials. It's just a fairly tedious task. This was the effect. There was a slightly better effectiveness of the fluticasone furoate vilanterol combination than usual care, and it didn't really matter whether it was instead of ICS-LABA alone or together with the LAMA, it was sort of fairly consistent. The interesting thing was when we then looked at the study afterwards and looked how many of these patients would have entered one of the exacerbation registration trials for the same drug, it was only 30%. So 70% of the people we had in the trial would never have gone into any of the larger trials looking at ICS-LABA combinations. Does it matter? Yes, because these were picked in the real population. It meant that they had far more exacerbations, for instance. They had twice the risk of being admitted to hospital compared to those who had been in previous trials. They also had far more pneumonias. And I think that's an important point. We always, when we do efficacy studies, say, yes, it's a little bit selected, so we may find different effects from the studies. But one thing is for certain, we'll always find less adverse events. Because usually in the efficacy studies, they don't have comorbidities. They're selected on being healthy and behaving in a healthy way. They take their medication. In the real world, far more pneumonias. Pneumonias matter with inhaled corticosteroids. This is from the TORCH trial, showing this 60 to 70% increase in pneumonias. And it doesn't really matter whether they're adverse events or people with serious adverse events, most of them hospitalized. Now you can see that the risk of being admitted is about 5%. In the sulfur lung study, it was about 6 to 70%. They all had inhaled corticosteroids, so we cannot say anything about the steroid effect. We can just look at it. So the question, of course, is if pneumonias become more frequent, does it matter? Because what if you're admitted with an exacerbation or admitted with a pneumonia? Which is worse? Because you reduce pneumonias, but you reduce exacerbations, but you increase pneumonia. So we looked at it, and this is 6 months survival after an admission in the sulfur lung study with either an exacerbation or pneumonia. And you can see it's far worse actually, to have a pneumonia and an exacerbation if you go to hospital. And of course people say, but these clinicians, these doctors, they cannot really tell the difference. Is there an infiltrate on the chest x-ray or is there not an infiltrate? Because that is the thing that really separates the two. So after having seen that, we asked 2 expert respiratory radiologists to evaluate the chest x-ray and says, is there an infiltrate or not? And then it looked like this. It was much, much worse to have a pneumonia. So I think we need to keep in mind that once we have efficacy finding, if there is an adverse event signal, we need to make sure what does it mean once we take the medicine, not just from the trial to the bedside, but also take it out in the population where it was never really tested. So it's not either or. It's not because the sulfur lung study is better than the efficacy trials. We need them all. This is a quote from Sir Michael Rawlins, who was the first head of NICE in the UK, saying that you don't need to argue the relative importance of these different study designs because they're all needed. And I think that's the crucial thing. You need to supplement your basic science, your clinical research with population research. I'll just come back to the statement that if it were true, because there were a number of observational studies on statins in COPD, and they all seem to be marvelous. You would give statins and people would live longer. So we thought we would look at it in our Copenhagen City Heart study because we had found that CRP increased the risk of mortality, and if you have increased CRP, you also increase your risk of hospital admission for an exacerbation, and we know that statins reduce CRP. So we thought, good, we'll have a look at it, but we'll do it much better than the others. I'm not sure we did, but we found that using statins reduced exacerbations by 33%. And about 15% of this effect was mediated through a reduction in CRP. It was all fine. We submitted it to Thorax and thought they'll probably take it. This looks nice. And then just as they had it for review, we had this study coming out, the StatCope trial showing no effect at all on exacerbations when patients were randomized to either placebo or statin. But this was not in a population. This was in selected patients with COPD who didn't have any indications for statin treatment beforehand. So everybody who already had a reason for having a statin could not go into the StatCope trial. So we repeated our population analysis, said, now let's do the same, let's take the same population, people with COPD who shouldn't have statins for other reasons. And when we did that, and I put it in this red box, you could see having statins didn't help at all. So we found exactly the same thing in that subgroup in population observational studies and in the randomized study. But when we looked at all COPD patients, we still found this. And to me, it signals that those who already had an indication and had COPD, they really should be on a statin. And it could be that it is the exacerbation driving cardiovascular event you reduce, and therefore in those who have risk of cardiovascular event and should be on a statin, they are double hit if they don't take a statin. They have their risk of heart disease, but if they have an exacerbation, they have an even higher risk of dying for cardiovascular disease. So I think population research can tell us something, because these patients will never go into a controlled trial. Who would take patients who need statins for cardiovascular reasons with COPD and randomize them to placebo? It will never happen. So again, it's complementary. It's not either or. You have to complement your clinical trials with your epidemiology. And of course, the same thing, when we saw there was an excess decline in those who ended up having COPD, why not try to decrease it? We were quite naive. We said, well, in the population, let's give half of these people steroids and half of them not. Copenhagen City Lung Study nested in a population study, no effect at all. You don't need to do statistical analysis on this. There was no difference in decline. But you can also see that the decline was not very big, because these were in the population. I'll come back to that, because I guess you all know that I will end on trajectories. In the TORCH trial with Bart as the first author, we could show that there was an effect of medication on decline. It was quite unspecific, because it was basically any medications would lead to a slightly less decline in lung function. I think we refined this a little bit in the SUMMIT trial, where we could show that combination treatment reduced decline in lung function by 8 mLs per year. And we could show that it was the component in the ICS-LABA was the ICS, because we had an ICS arm. There were 4 arms in SUMMIT, one on placebo, one on vilanterol, one on fluticasone furoate, and one on the combination. Whereas if we looked at those who had the beta-2 agonist, they may have a slightly higher raise in lung function to begin with, but their decline was no difference. So 8 mLs is not a lot. It's not a reason for prescribing inhaled corticosteroids to everybody, but it gives us a hint to take to both the clinicians and the basic scientists that there is a subgroup to be looked for. It may be the ones with eosinophils, but we don't know for decline yet. But we have a hunch. In general, we do not know very much, or we didn't 10 years ago, about what happened to decline in lung function once people got down here. And Fletcher and Pito never studied them. We know this graph from the Fletcher and Pito paper. They looked at healthy men. None of them had COPD. So this was just their idea of how COPD developed. I was lucky enough to be involved in the ECLIPSE study, which I think was a model study for collaborations between academia and industry. This was a collaboration with GSK, but the agenda was very much driven by the academics in the group. And one of the studies we did was that we looked in changes in FEV1 over 3 years in patients with COPD. And to our surprise, the mean decline in FEV1 was 33 mLs per year, which is more or less what you would expect in a healthy decliner. It was not the 60 to 80 mLs per year that we would expect. So what on earth was happening? And of course, not surprisingly, and others had given this some thought in other settings, it all comes back to figure 2 from the Fletcher and Pito paper, which far fewer people know than figure 1. Figure 2 is interesting because they used it to denote that if you measure lung function, a single lung function measurement at something age 50, and it's slightly lower than expected, you have no idea of knowing whether this is somebody racing down with an accelerated decline, will develop COPD and die from it, or whether it's somebody who just didn't have normal lung function to begin with, and who at this pace will just lose a little bit of lung function every year and never be bothered by it. And I think this is important because this also denotes that you can reach COPD by different trajectories. I'll not go into detail, but I was happy enough and lucky enough to be part of this paper where we analyzed the Copenhagen City Heart Study, the Framing of Offspring cohort, and the Loveless COPD cohort. We tried to sell it as 3 papers to New England Journal of Medicine. They didn't buy that one, so we did a pooled analysis. And what we found was that we looked at these simplified FEV1 trajectories, and we could find that if you had somebody walking into your clinic with Gold 2 or worse COPD, there was a 50-50% likelihood that either they would have come because of rapid decline, but actually 50% of them would be there just because they never had normal lung function, but developed airflow limitation. It took 25 years of follow-up to see this, but I think it is important. It's important because usually when we study COPD, we do it in the small circle on the right side, whereas actually if we, for basic research purposes, wanted to know something about COPD development, we should sample people much, much earlier. So what you do as a clinician when somebody from the lab comes and says, I need some COPD sample, we're doing this new tissue biomarker for COPD progression. Can you give me some patients? Well, you don't go to your 8-year-old patients. You find some of your younger COPD patients, for example, those in the circle, 50 to 60-year-olds. We take out the normals, and these are the patients you can sample. And then we say, oh, and by the way, we can tell you these people have mild COPD, and these people have severe COPD, so now go find your biomarker for progression. And we're surprised that it doesn't work. Of course it doesn't work. Down here, it's all metal together, and we have no way of saying how people arrived at this point and how they will progress. In the UK, we're currently looking at 550 young people with normal lung function who are smokers to see if we can pick up signals very earlier that they are rapid decliners or not. We do know what affects growth of lung function. This is Diane Gold's paper looking at smoking, and there are others. We, many years ago, thought that socioeconomic status and lung function was not relevant in a fairly well-off country like Denmark, and we were slightly surprised when we look at the Copenhagen City Heart Study, and after adjusting for smoking, the difference in FEV1 between somebody with a good income and high education and somebody with low education and low income was on average 300 mLs in adulthood, which is basically the same difference if you take all smokers compared to all non-smokers. And you can see that age doesn't really matter because you could think, is this occupation? No, it is very likely to be growth because social status is tracking, not just tracking with age, but tracking with generations. So it just shows us that the damage from low socioeconomic status is already done before you're an adult. Difficult. This is from the Tucson cohort study by Fernando Martinez and others, just showing that it's not just about having low growth in lung function or high growth in lung function. This is biology. There are all things in between. And therefore, in individuals, it's difficult to determine, and it makes epidemiology of growth trajectories challenging, I would say. But I think one thing is for certain. When you look at these simplified FEV1 trajectories, and remember that 50% of COPD comes from the black line, it really tells you one thing for sure, and that is prevention is key in COPD. Prevention is not stopping 60-year-olds smoking. That is secondary, if not even tertiary prevention. Preventing COPD starts very early on, probably at conception, but at least early in life. It used to be smoking. Where I work now, it's very much vaping. You could say, well, we don't really know if vaping is that bad for your lungs. I guarantee you that it is. Of course it is. Lungs are made for breathing in clean air. Breathing in vaporized, heated chemicals, would that be good for your airways and lungs? Of course it isn't. And that's not the real dangerous part on this. The dangerous thing is what nicotine in these vapors do to their brain. Basically, if we let our young people use e-cigarettes with nicotine, we turn their brains into addictive brains. The pathways for addiction get reinforced, and I'm sure that those who vape, there will eventually be more cigarette smokers in that group than there is in those who do not vape. It is bad in our part of the world. If you go to poorer parts of the world where you now combine poor socioeconomic status with smoking, you're really in trouble. And I think that has been shown on numerous occasions. Another thing from the ECLIPSE study was the focus on exacerbations. Now, the term frequent exacerbations was not coined by Eclipse. There was already talk about frequent exacerbators before the Eclipse study, but the Eclipse study could put numbers on this fact that if you had had exacerbations, frequent exacerbations both last year and the year before, you probably had an 85 to 90% likelihood of having frequent exacerbations again next year. And likewise, if you didn't have exacerbations in the last 2 years, there was an 80% likelihood you wouldn't have exacerbations next year. All very helpful. But trying to find targets and promote further research, we also looked at biomarkers of inflammation, systemic inflammations, for instance. And it was associated with an increased risk of exacerbations. It more or less disappeared when we controlled for history of exacerbation, but that doesn't take away the fact that it could be promoted through systemic inflammation. So you might think I can identify people with high risk of exacerbations by using systemic biomarkers. But then you take this out in the population, and it is different. Because in the real population, there are much more non-exacerbators, and I think that's a crucial thing. So in our Copenhagen General Population Study, we took 6,500 subjects with spirometry-defined COPD, so they may not be sick. But nevertheless, in these, we could find more than 3,000 healthcare-utilized defined exacerbations. And it was using registers, so we were quite sure of this piece of information. And what we found was that if we then looked at CRP, white blood cell count, and fibrinogen, having one elevated increased your risk somewhat, having two of them elevated increased your risk, and if you had all three increased, it would increase your risk of having exacerbations by 6 times. That sounds very high, but there were so few of them. So whereas you think from bedside that you can use inflammatory markers to predict exacerbations, in the real world, you can actually look at absence of biomarkers and predict non-exacerbators. So you may think it's the same thing, but it is not, because having increased systemic inflammation does not have very good sensitivity and specificity, but having no biomarkers is a much better thing to work with. So different signals, whether you look at bedside or populations. But exacerbations are not really about biomarkers. Exacerbations are about exposures. And many people think this is a grandmother with a grandchild. It is not. It's a COPD patient holding their virus canister just in front of their nose, ready to inhale whatever comes out of the canister, and it's a lot. How do we know? We know because a lot of COPD patients can tell us that when they are with family, they have a high risk of exacerbations. And in epidemiology, we sometimes have the luck of having natural experiments. The natural experiment I'll refer to was the COVID-19 pandemic, because a lot of studies have subsequently looked at what happened with COPD exacerbations during close down, lockdown, whatever you called it, during COVID, and there was a 50% reduction in admissions for COPD exacerbations during the COVID-19 pandemic. A few optimists would say it was because people got scared and used their medication, better adherence. I think it was because they were shielded. And of course now we do not have the same attention to distance, probably a bigger problem in your part of the world than mine. Of course, where I work, it was never really a big issue, this thing about having distance, but it probably was in other parts of the world. So I think if we take our job seriously, we need to learn from these natural population experiments. It's not very nice to tell your patient, I mean, if you tell your female grandmother patient that they cannot take care of their grandchildren, you'll never see her again. She'll find a nicer doctor next time. But you need to discuss it with your patients because it's a clear learning from populations that shielding works. So you think, is it that bad being a grandparent? Not at all. Those of you who are grandparents will know all the pleasures it brings, and in COPD it does have benefits. So Judith Garcia Emmerich's group in Barcelona looked at factors that would increase the likelihood of physical activity. So for instance, having a dog would mean 18, this is a time spent 18 minutes extra every day spent walking because you had a dog. And you think, is this just a chance finding? No, we see the same in the Copenhagen City Heart Study. We also see that having a dog reduces your risk of being admitted to hospital. I don't really think it does. But if you have COPD and a dog, and you're admitted to hospital, and you get to A&E, and there's this junior doctor saying, "Oh, Mr. Smith, we must keep you in hospital," you say, no, I have to go home and look after my dog. So it's perhaps a proxy finding that it protects against hospitalization, but nevertheless. But look at grandparenting. It is surely good for men, but not for women. Is that strange? No, it just illustrates what I said. Because I would assume that in Barcelona, if you're a grandfather, you have your grandchild when they're healthy, and you can walk down to the park and meet the other grandfathers and their grandchildren. Whereas when the grandchild is sick, the grandmother takes care of them, and therefore it's not an advantage for her. So again, population to bedside. The final thing I will touch on when talking about population and bedside is the thing about e-cigarettes. Of course, this is where I think population studies can play a big role. Many of you will know this randomized controlled trial of e-cigarettes published in the New England Journal of Medicine, showing that there was a much higher likelihood of being a non-smoker after 12 months if you had e-cigarettes than if you had other nicotine supplements. So clearly, fewer smokers. It did not have the same positive benefit on nicotine addiction. There were far more people, of course, continuing with the e-cigarette than there were abstainers continuing with their other nicotine substitution. But it reduced smoking. So subsequently, more or less the same group have done a Cochrane review. And again, if you look at controlled trials, you can see that using e-cigarettes is good because it reduces smoking, which is what we all want to achieve. We want people in the community, in the population, to stop smoking. But other people do other types of systematic review and meta-analysis. So this is Linnea Hetman from the north of Sweden. She did the same analysis, and this is looking at controlled trials. And she finds exactly the same thing. There's one or two more trials here, but clearly in clinical trials, e-cigarettes reduce your risk of being a smoker a year later. But when she looks at population studies, there's no effect at all. No effect. And it's because once you're outside a clinical trial, all those who were not in the clinical trial will also use e-cigarettes. They'll not get the same advice. They may give up smoking, but because they're not in a trial where they're asked all the time whether they smoke, they'll become dual users. So they may reduce their smoking a little, but now they both use cigarettes, and then when they are in a place where they're not allowed to smoke, they will vape. So in populations, there's no effect at all. And the really terrible thing is that in the clinical trial, I've told you previously, you're not good at measuring adverse events or adverse effects. You're not reading this meta-analysis either, because it doesn't include this guy who starts his nicotine career by being a vapor, because the alternative for him to vaping is not smoking. The alternative is just as much not smoking and not vaping. And that's where population knowledge tells us that we have a problem, and it is never addressed in any of the trials of e-cigarettes. So at the end, because I will not bore you with more epidemiology at this stage, I'd like to thank a few people. These three people started the Copenhagen City Heart Study back around 1970. They're all still active. They are now doing the 7th panel study of the Copenhagen City Heart Study, which is a 50-year follow-up. They were all appointed cardiologists, the two on the left, and one of them, the guy in the middle, is still active. Merete Appelgaard was a technician, a laboratory technician, and she has participated in panel studies of now more than 60,000 subjects, if you count the many times they came in. I'd also like to thank three other people. Børge Nordestgaard, who was a person who was involved, he's a genetic epidemiologist, and he wants to do cancer genetics in the Copenhagen City Heart Study and found that it was too small. He didn't have cancer cases enough. So he said, I'll do, instead of 14,000 people in the Copenhagen City Heart Study, I'll do 100,000, he said. And everybody said, you're crazy, Børge. And Peter Lange in the middle and myself said, we also think you're crazy, Børge, but if you are crazy, could you do spirometry on all of them? So he did 110,000 people with spirometry, and we've now done repeat spirometry on 65,000 of them. His latest idea was he would do CT scans. And we said, no, Bo, you cannot CT scan 100,000. He said, no, I'm not mad. I'll do 30,000 CT scans. We said, you're still mad, and he's now done 24,000 of them. So things can happen when you have a really enthusiast like Bo. Peter Lange in the middle is my good friend and colleague, and without him I would not have done very much research. And Jakob Marot, the young guy in the bottom corner, is the guy who actually analyzed the trajectory paper with the pooled analysis. He's a brilliant statistician, and my lesson to all of the young people in the audience is never ever forget to give credit and warm thanks to your statistician. Because if you're a clinician doing epidemiology, you are nowhere without a good statistician. With this, I would like to hope that I've convinced you that population adds to what we do in our clinic, how we learn, how we apply new knowledge and want to test new things at bedside or at the bench. And I'd like to thank you for your attention. Thank you. Thank you.
Muchas gracias, doctor Vestbo, por su magnífica presentación. Me gustaría pedir a nuestro presidente, el doctor García Río, que se acerque un momento, porque le vamos a hacer entrega al doctor Vestbo, en nombre de SEPAR, de la insignia de oro SEPAR por su contribución a la medicina respiratoria y al cuidado de los pacientes. Doctor Vestbo, we are happy today having the opportunity to offer you our SEPAR Gold distinction because of your contribution to respiratory medicine and patient care. Thank you very much for staying with us today.
Very honored.
And for you.
Thank you.
Thank you very much.
Thank you very much.
Sí.
Yes.
Thank you very much.
Thank you.
Por esto.
Questions?